Hey there, this is Luke Maxfield with MedSchoolCoach. I'm a tutor for USMLE 2, 3, COMLEX 1, 2, and 3. Today we're going to talk about one of my favorite topics, atrial fibrillation. It's just something that's so nuanced. There's so many questions you could build out of this. There's been some recent updates lately, and we'll kind of talk about those and go through mostly the treatment of the condition. This will be more focused towards the step 2 exam. But let's take a look at the question here. So here we have a 54-year-old female, comes to the emergency department, has the complaint of not feeling good. The patient has a history of congestive heart failure with reduced EF. She has hypertension, diabetes mellitus, medications, lisinopril, aspirin, metformin, has 8 cups of coffee a day, multivitamins, cannot remember when it started, afebrile, stable blood pressure, tachycardic, irregular pulse, O2 is fine, respirations are fine, EKG is provided, BNP 70, troponin 0.02, CBC, CMP within normal limits. What's the most appropriate next step? So there's a lot of information in this vignette. And this, again, is one of the reasons I think atrial fibrillation is beautiful, especially for testing purposes. So if you have a patient with atrial fibrillation, you should probably be thinking in terms of establishing diagnosis. Is the patient stable? Then how do we treat? And when you're thinking about treatment, we're thinking about hemodynamic stability, cardiopulmonary involvement, rate control versus rhythm control, and anticoagulation. So every time I see a question that's taking me down atrial fibrillation, that's where my mind automatically goes. Then we look at comorbidities. So this patient has congestive heart failure with reduced EF. That's actually important for atrial fibrillation. Hypertension, diabetes, medications, lisinopril, aspirin, metformin, coffee daily. Sometimes you'll have a younger, healthier patient who comes in with just a ton of caffeine use, and that can trigger some sort of arrhythmia. And then vitals. So again, it's very important the patient's stable. Heart rate, we'll talk about the windows and your goals for rate control. It's irregular or irregular would be even more telling. They'll give us an EKG, we'll look at it, and then also they give us some initial labs, BNP, troponin. So the first thing to do when you get an EKG, keep it simple. So looking at EKGs, everyone has their own system. So it's broken down. We have the individual leads, we have the rhythm strip. My eyes go right to the rhythm strip because the quickest things I think I can establish are what's the general rate? Is this a regular rhythm if they hadn't told me? And then from there, look at the individual leads. The way I approach this first. So general, I look at the rate. They didn't give me vitals. So quickest way, 300, 150. So at the time this EKG was taken, she's not particularly tachycardic, but we're still going to go with the pulse and the vignette just for educational purposes. The next thing I look for here is just the overall organization of the rhythm. So by that, I mean, I'm looking for the P, Q, R, S, T. So look at this. Where are those P waves? Is this one? Is this one? Is that one? Basically, there aren't any consistent P waves. The QRS complex is easier to pick out. And if you had calipers or even a piece of paper in a test where you just draw 2 lines, you hold it up to the EKG, seeing if they mark out at regular intervals. In this case, it won't because there's no discernible P wave. We have an irregular rhythm. It's consistent with atrial fibrillation. Another thing to consider, especially when you have an irregular rhythm, is multifocal atrial tachycardia. And then always, as soon as you hear that word, you have to think about COPD because it's the most common arrhythmia associated with COPD. So now we've established the patient has atrial fibrillation. You can probably move on in this vignette because we already know what we're looking for. Okay, so now let's go back to the vignette. We're looking at what's the most appropriate next step. And we're going to look at the information in the stem and compare it to the distractors that we're given. So synchronized cardioversion. What's the role of synchronized cardioversion in patients with atrial fibrillation? Cardioversion, atrial fibrillation, it's not your most appropriate next step or earliest step in treatment unless the patient's unstable. So here, blood pressure is stable. So cardioversion is out. And there's a difference between these two, but we'll talk about that a little bit too. IV sotalol. So you need to have in your mind what medications are used for rate control or rhythm control. So rate control is where you're just interfering with the ability of the atria to conduct the impulse to the ventricles. So while the atria is quivering here, the ventricles are randomly catching on through the conduction through the AV node. And so in AFib with rapid ventricular response, it's like this. And we want a medication that acts here on the AV node to block and slow down that conduction, something more tolerable. Now, this is the reason I like sotalol as an alternative distractor to metoprolol, because they're both beta blockers. But sotalol is actually a class 3 antiarrhythmic and acts also to medically cardiovert patients. So part of your knowledge base that you need to come armed with for atrial fibrillation is the benefit and risks as far as rate control and rhythm control. I'm going to go into more detail there, but for now, I'm just going to tell you rate control is equally efficacious with a better side effect profile for initial therapy. So sotalol is out because we're looking for something rate controls. And then here's another combination here. So metoprolol, beta-1 selective beta blocker. So we do know that it's going to slow the conduction through the AV nodes. That gets a star from me. It looks like a great option. And the diltiazem, which is a calcium channel blocker, would also affect the AV node. Now here's another caveat of atrial fibrillation. And again, this is just why I love the topic. It's so testable. Is what about this patient makes diltiazem important? And it's CHF with reduced EF. The use of calcium channel blockers, especially diltiazem, in acute episodes of atrial fibrillation in patients with reduced EF, congestive heart failure, have increased mortality. So that's out, which leaves us with IV metoprolol. So let's talk about atrial fibrillation just a little bit. It's an abnormal atrial premature beats, again, with electrical stimulation that gets conducted to the ventricles. The AFib is actually the fibrillation of the atrium, right? And then most of the symptoms are felt because the ventricles, which control the majority of the blood outflow, are responding and catching electrical stimulation and contracting in a rapid and uncoordinated way. It's most commonly a secondary to structural changes, whether from hypertension, previous cardiovascular disease, congestive heart failure, or even obstructive sleep apnea. And then often patients have nonspecific symptoms like palpitations, lightheadedness, malaise, chest pain. They can have syncope, and then it's diagnosed largely by physical exam and EKG. So with the treatment, we talked about this. We want to prevent strokes because when the atrium is fibrillating, the blood is not moving out in a consistent manner, and that stagnant blood is risk to clot. And those clots can be sent into the systemic circulation, especially from the left side of the heart, causing a cerebrovascular accident. That's the main thing we want to avoid other than cardiac ischemia. The second thing is rate control, and this is where cardiac ischemia and cardiac damage comes in. So if the ventricles are quivering or contracting at a rapid and uncoordinated rate, that's a lot of extra work that those ventricles have to do. And in patients with pre-existing coronary artery disease, they already maybe have some mild demand ischemia, and this could exacerbate that significantly. And then the third thing to consider when you're treating these patients is down the road, if their symptoms do not improve despite decreasing the risk of stroke and controlling the rate, then you can talk about symptomatic therapy. So now how do we treat it? Rate control. Your goal is a beat per minute of 60 to 110. In most patients, you can use either beta blockers or the non-dihydropyrimidine calcium channel blockers. But like we talked about, a nice testable point, calcium channel blockers increase mortality in patients with congestive heart failure and reduced EF. Now digoxin, another highly testable medicine. So this is adjunctive in patients with heart failure. What does digoxin do? What does it not do for these patients? Well, it might increase mortality, and we use it for is really just as a therapy for patients who are very hemodynamically unstable with severe left ventricular dysfunction, really because it has less of an effect on their blood pressure because it's a concomitantly an inotrope while it's slowing the conduction, as opposed to a beta blocker, which not only decreases the pulse rate, but also maybe have some decreased contractility of the heart, further exacerbating maybe severe hypotension in a patient with AFib and RVR. So if they're hypotensive, another good medication to use is amiodarone. So if they give you a patient with borderline hypotension who's not unstable enough to shock or cardiovert, then you need to be thinking amiodarone. Another very unique testable point is if the patient has a delta wave, which can be seen on EKG or history of Wolff-Parkinson-White pre-excitation. You do not use a calcium channel beta blocker. So this is a crude heart. So normally all of the conduction is going here, right? Through the AV node. These patients have an accessory tract. So if you block the AV node with calcium channel blocker or a beta blocker, then all of that conduction gets shifted to that accessory tract, and it can greatly increase the risk of deterioration into a more malignant arrhythmia. And this is the one time procainamide is going to be the first-line treatment on your test, unless you're talking about maybe drug-induced lupus, but procainamide is a first-line treatment in patients with atrial fibrillation or Wolff-Parkinson-White. So when do you cardiovert these patients? Again, when their heart's fibrillating, they have an increased risk for clot formation, so you don't want to do it right away, because if you all of a sudden get this regular, organized contraction of the atrium, ventricles, you could be pushing out all of the blood or the vast majority of the blood, which would include the clot, and that clot can then enter the systemic circulation, including the carotids, and then causing a cerebrovascular accident. So you generally anticoagulate these patients before cardioverting them. But when you have to do it urgently or immediately, if a patient has myocardial ischemia, which would be evidenced by an elevated troponin or BNP because of strain on the right ventricle, or the patient is overtly unstable. And then when you do cardioversion, it must be synchronized to prevent an R on T phenomena and then cause subsequent ventricular fibrillation. You can, in addition to electrically cardioverting these patients, use medications such as flecainide, propafenone, or ibutylide to cardiover to convert the rhythm in these patients. So if the patient has AFib, duration unknown, or it's been going on known for longer than greater than 48 hours, that's the time frame they contribute to being a risk for thrombus formation. Then you need to do a transesophageal echo to rule out a thrombus. Transthoracic is not sensitive enough to rule out a clot formed in the atrium. And then if you do find a clot, then you need to use a NOAC or novel oral anticoagulant. And we'll talk about the nuances of the anticoagulants as well. But NOACs have become a first-line treatment. So taking a similar yet, a 50-year-old female admitted new onset atrial fibrillation, history of CHF, reduced EF, hypertension, diabetes, mellitus, same patient. So we started her on IV metoprolol like we said we were going to. Pulse is 110, still has an irregular rhythm. Now what? Do we do warfarin, heparin, aspirin, or because the pulse is elevated, do we need to give her more? So we talked about our goals for pulse, 60 to 110. I even gave you the extra caveat, the symptoms have resolved. So we know we do not need to bring her pulse down anymore. Now the question becomes anticoagulation, and here's where another testable point comes in. We have to risk stratify the patient using the CHADS 2 VASC score, and then we also have to think about, do I need to bridge this patient? By bridge, I mean, do we need to give heparin, which works immediately, and then give them warfarin, which has a time delay to onset of anticoagulant activities. And because of this testable point, I left out the option of NOACs, which work immediately. So in this patient, we actually, 1, need to anticoagulate, 2, don't need to bridge. So anticoagulation. NOACs, novel oral anticoagulants, NOACs are now the preferred treatment of choice, with digoxin being the newest player, and it's indicated for any non-valvular, which is a former term, atrial fibrillation. Non-valvular means any atrial fibrillation that's not caused by moderate to severe mitral stenosis or mechanical heart valve atrial fibrillation. That's the group that's fallen into valvular. Any non-valvular atrial fibrillation is going to get a NOAC as a treatment of choice. People who are not candidates for NOACs, end-stage renal disease, not studied in pregnant patients, so pregnant patients, cancer patients, or any blood clots associated to ongoing cancers, or BMIs greater than or equal to 40. So if a patient is not a candidate for a NOAC for one of those reasons I listed before, or if the patient has atrial fibrillation from mitral stenosis or mechanical heart valve, that's when you use warfarin, okay? And then unlike other venous thromboembolic diseases, you do not need to bridge or give heparin before warfarin for most patients in the setting of AFib. And then that was put out in 2014, mostly based off of the bridge trial and put out into the guidelines, okay? And then some of these valvular indications changed also in the 2017 focused updates. There have been a lot of focused updates over the last decade on this topic. Okay, we're talking about risk stratification now. Again, there was a 2019 focused update. I think at this point, it being 2020, it's probably too soon to see it on your boards. So I put the previous scoring system, the simplified scoring system on here, but just know that there was an update. So the CHADS 2 VASC score, C, congestive heart failure, H, hypertension, A, age, D is diabetes, S is stroke, VA is vascular disease, S, the last S is sex for female. So everything is 1 point except the age greater than 75, and it's an additional 1 point, so this is 2 points. And then having had a previous stroke is 2 points. A score of 0, no anticoagulation needed. A score of 1 means the patient is low risk. The old traditional method, aspirin monotherapy, was an option, may still be testable, maybe not. Now it's more like talk to the patient. They have a score of 1 about the risks of bleeding versus stroke, and make a mutual decision on whether to fully anticoagulate them. And the verbiage they use is consider oral anticoagulation, or do nothing. And then greater than or equal to is a definite treat. And this table is actually one of my favorite tables just for patient education. It lets you put a number on their risk for stroke. And part of this study was done over a prospective period of following patients for 1.5 years who were on or not on oral anticoagulation, and the risk of ischemic stroke was calculated based off of this. So a patient with a score of 0 has a 0.2 risk of stroke. I think it's 0.2% risk of stroke. Score of 1, 0.6% risk of stroke, up to maybe, let's say a score of 9, and 12.2% risk of stroke over 1.5 years, but it can be extrapolated into patient years. All right, it's a lot of information, a lot of testable things. maybe you need to go back through and watch it again just to clean some of the points, look at some of the tables longer, look at some of the caveats in a little more detail. But I hope you enjoyed it. It's a challenging topic. It's very high yield for tests and just so important to know in the real life because it's such a common disease. You're going to see these patients. Take care. Enjoy. Good luck.